Thank you. Good morning, everyone. Thank you so much for joining us on this Wednesday. We're excited to hear from our members who have graciously volunteered to share their experiences with us all in this this format. We're gonna continue. We'll have a couple of different meetings that will follow a similar format. We're gonna maybe mix it up a little bit, but yeah. So next slide. Yeah, so today we're just going to have folks drop in the chat if you don't mind sharing your name, your role, and then something you are looking forward to about summer. So my name is Jessica Hamill. I use she, her pronouns. I am the local maternal child health coordinator at the Michigan Department of Health and Human Services. So I oversee the Title V maternal child health block grant funding that goes out to all 45 local health departments. And then I also assist on this project. And something that I'm looking forward to is our family. We are tent campers. So we always like to schedule at least two big tent camping trips over the summer. And so we will be visiting PJ Hoffmeister State Park this year and then the Harrisville State Park. So that's what we are looking forward to. Oh, looks like gardening and fishing from Lisa. Oh, birthday. Well, happy early birthday, Kristen. Oh, friends pool. I love pools. I always wanted a pool. But now that I'm a homeowner, I'm like, ooh, I don't want that insurance liability for the cleaning. More gardening. Ooh, boating. Oh, more boating. And yes, the recording will be shared. Gardening, getting out in the sunshine, eating outside and gardening. Yes, boating, more boating, swimming, ooh, hiking, visiting Lake Superior. Oh, glampers, you're getting out there. Dr. Gilbert would love it. Warm weather, going on vacation, boating in warm weather. Well, awesome. Thank you all for sharing. I know you can tell we live in where it's cold most of the year. These are virtual meeting guidelines. I think most everyone is familiar with these, but yeah. So we can just cruise on by these. Next slide, please. Just trying to keep connecting the dots. So sort of the project purpose is to understand the current pediatric medical home landscape and systems gap. And so we're really excited to kind of dig deeper into that with the wealth of knowledge and experience that we have from you all, our members, as we continue to have conversations, thinking about what role Title V might have, the maternal child health block grant in advancing medical homes for children across the state. And then also selecting at least one pediatric medical home system gap to focus Title V support. But then we also want to think about how, we can engage partner, sort of beyond the scope of Title V. And that's where you all are coming in and helping us sort of work through what makes sense and how we can engage our partners and stakeholders in this work across the state. It is a beast. Next slide, please. And then our community agreements, just, everybody knows this, but just be open, respectful, and actively participate. And especially over the next several meetings, folks will really be sharing their experiences. And, some of those may differ from one another. And that's okay. Like that just helps us better understand the perspectives and the system that we're sort of all working within. And yeah. All right. And then am I kicking it back over to you, Lindsay?
I'm going to take over from
Gloria.
here.
Sorry.
Hi, everyone. I'm Gloria.
Thank you,
yeah, thanks, Jessica, for welcoming us. Today, we're going to really focus on learning how system-level partners perceive the effects of policies, practices, and resources have on the medical home system for children. And so in order to do that, we're going to first we'll do a brief overview of what we talked about in April. Then we're going to have someone share a bit about the patient-centered medical home accreditation process. And then we're going to have a systems level panel discussion to hear from some more of our members of this advisory committee to hear more about their perspective. Then we're going to do a little bit of group brainstorming together and wrap up. And just to give a reminder of the model of systems change that we are looking to in this process, these are the 6 conditions of systems change: policies, practices, resource flows, relationships and connections, power dynamics, and mental models. And we're using this in order to really get at multiple ways in which we can change and influence the system of medical home for children. And so today we're really focusing in on the top piece of this upside down triangle, the policies, practices, and resource flows. And today we're kind of focusing in on the systems level partners. And then next week, we're going to be hearing from parents and healthcare providers about their perspective on these policies and practices and resource flows. And then later on in the summer, throughout June and July, we're going to hear more from parents and healthcare providers around like the mental models, the power dynamics, relationships, and connections, and hear their experiences on navigating that, where there's opportunities for change and partnership. Yeah, and then once we get into August, that's when we're going to do some collective deciding and prioritizing of what we want to focus on after we've kind of heard from a wide variety of folks of different opportunities that we could look to. And so just to give a little summary of what we talked about last time, last month, we went through some data for the Consumer Assessment of Healthcare Providers and Systems, or CAHPS. And this information, just as a reminder, really looked at ratings that participants in Medicaid managed care programs made of their health care, their health plan, and different elements of their care. And so some of the key observations that we looked at in terms of strengths, some of the strengths: communication with doctors was rated highly by participants. Some of the barriers that we saw that patients are experiencing are getting timely appointments and transportation to appointments. And then we also saw that healthcare plans ratings varied across different factors. There wasn't one health plan that's doing really well overall, or one health plan that's doing poorly overall. It was really a mix of strengths and weaknesses across those different factors. So there's kind of unique strengths and unique weaknesses to each of those healthcare plans. And then y'all brought up some really important questions. Folks were wondering about what are the root causes related to that lower rating of health plans and health care. Is it due to the fact that people are having difficulty accessing appointments, or other factors? Folks were wondering what the response rates were like, and if those were mostly driven by folks with poorer experiences who are more likely to want to share their poor experience as opposed to someone wanting to share their good experiences. And folks were also wondering why we saw the doctor's communication rated highly, while also saying that personal doctors was scored low, and kind of wondering what the disconnect is between there. So we'll kind of keep those questions in mind as we kind of get into our systems discussion with partners, with providers, with parents, to see if we can kind of get at some of these questions. And another thing that we did last time was that we went through the definitions of the core elements of a medical home, and we kind of agreed upon what we want to move forward with. And so these 7 elements are what we kind of collectively agreed we want to center in our discussions around medical home. Comprehensive care with a personal health care provider, usual source of care across the lifespan, coordinated care and needed referrals, compassionate care that centers the family and their culture, quality and safety, accessible care, and a payment structure that encourages patient-centered care. And so we've got a full detailed document with definitions that I believe we sent out to you, but we can always, if you missed that, even if you'd like to see it, we can send that out too. And then we also spent some time brainstorming who the different partners are at within each of those core elements. And so we took those lists that you all created of all the different partners. We could have created this map that shows like those high level categories of people and partners. So we put children and caregivers kind of at the center of this medical home ecosystem. And then the key partners kind of around this wheel being the care team, administrators or clinical staff, payers, technology, governance, and that can include kind of government and also different boards or accreditation bodies that kind of keep track of quality and safety. Healthcare systems, whether that be kind of the training system, hospital systems, as well as community-based organizations that are kind of helping folks refer and get coordinated to different services that they need. So that kind of gives an overview of what we talked about last time.
On the floor.
Yes.
You know that.
And so today, what we're going to be moving into is that systems level discussion. And we're going to start with hearing about the patient-centered medical home accreditation process. And this is one way that that we see medical home being incentivized or kind of a structure being given to it. So we wanted to share this information in order to better understand what are some of the options in terms of systems change related to medical home. So very pleased to introduce Dr. Jessica Hahn, who is going to share with us. Dr. Hahn is a board-certified pediatrician with over 20 years of clinical experience. She earned her medical degree from Wayne State University and completed her pediatric residency at New York University. And she currently works with Blue Cross Blue Shield of Michigan as a medical director in clinical partnerships. So Dr. Hahn is passionate about primary care and is dedicated to advancing team-based care through the development and implementation of programs that support both primary and specialty clinics. So with that, welcome, Dr. Hahn, and I'll pass it off to you.
All right. Well, thank you so much for inviting me to speak a little bit about Blue Cross Blue Shield's patient-centered medical home program. Full disclosure here, I have been primarily working on the patient-delivered care management team over the last couple of years, but this program, the PCMH program, is foundational for PDCM. So I should have a fairly good understanding, and if you have questions that I can't answer, I'm happy to take them back to my group and make sure that you get the answers that you need. And hold on, my computer just went a little crazy, so I have to figure out how to get back to where I need to be. Okay, there we go. All right. All right, so can we go to the next slide, please? So as we've talked about extensively in this group, the concept of the patient-centered medical home is to provide a care delivery model in which the patient's treatment is coordinated with the primary care physician to ensure that patients receive the necessary care when and where they need it in a way that they can understand it. So the role of the PCP is very important in this model, and it really supports overall population health by ensuring collaboration and communication of care between all the providers that are touching the patient. So just a little bit of history. Blue Cross Blue Shield of Michigan started their patient-centered medical home program in 2012, and it's grown significantly since that time. In Michigan, 99% of counties in the state that have a PCP actually have a Blue Cross Blue Shield of Michigan PCMH designated practice. And this program has been recognized nationally and profiled in many different medical journals. So time for some of the nitty-gritty details. So the process to become a Blue Cross Blue Shield of Michigan patient-centered medical home practice involves a few steps. The first is that a practice must be a participant in our PGIP program. So I'm going to give a high-level overview of what PGIP is, but this could be like a half-a-day presentation in and of itself. There is a lot of information about the PGIP program on our website if you're interested in more detail. But for those of you who aren't super familiar with this particular initiative, PGIP began in 2005, so it's now 20 years old. It was actually developed by a collaboration between Blue Cross Blue Shield of Michigan and the Michigan State Medical Society to help identify ways to develop and foster relationships between Blue Cross Blue Shield of Michigan and physician organizations throughout the state to transform care, build infrastructure, improve performance, and achieve overall cost savings. Participating physicians are rewarded by improving their performance on quality measures, providing cost-effective care, and improving patient outcomes. And we currently have 33 POs that are in our PGIP program. So that's the first step. Then the physician organization needs to nominate either the practice or the provider. And in order to be designated, practices must have a minimum of 50 PCMH capabilities in place, including the 15 core capabilities that are required. The core capabilities are really central to the patient-centered medical home model and include domains like provider and staff training, results sharing with patients, access to 24 hours a day, care, and connection to community services. So, and the other metric that is looked at is the practice must have a quality and utilization score greater than the 20th percentile. The quality component calculations are made up of several metrics, and for pediatrics, they include well child visits, adolescent visits, immunization rates, counseling for things like nutrition and physical activity, and the utilization piece really only includes the rates of primary care sensitive ED visits and low-tech radiology use. So when they're designated, practices receive the patient-centered medical home designation for a 2-year cycle, although they can be nominated on off years by the mid-cycle review process. Site visits are done annually for selected practices, and demonstration of the capabilities marked in place may be required. So for example, if a practice says that they're doing test tracking, they would need to be able to show the process or procedure documented in the office, as well as be able to demonstrate how a test was tracked for a specific patient. If a practice falls below 50 capabilities, does not have the 15 core capabilities in place, or falls below the quality utilization score of 20%, they are in danger of losing their PCMH designation. So one of the questions that was asked of me is what areas of the PCMH program are easier to achieve and what requirements might be a little bit more challenging? And in response, I would say that actually meeting the 50 PCMH capability threshold, which sounds really hard, is actually probably the least difficult part of the PCMH designation process. We currently have over 180 capabilities practices can choose to implement. And even among the 15 core capabilities, these are often things that practices are already doing, like 24/7 call, test tracking, referrals, and monitoring patients for gaps in care and making appointments when they're needed. There are some that are a little more challenging, such as tracking specialty referrals and integrating them into the system. However, in general, practices can choose which capabilities they would like to focus on. And if a practice begins by developing specific protocols for work already being done in the practice setting, that's actually relatively low-hanging fruit and will rapidly get them to that 50 capability performance level. And on the flip side, the performance score is actually what can be the most difficult measure to achieve because the scoring methodology is relative to how all the other practices in the state are performing. So due to the relative ranking, practices may maintain their specific performance, but drop due to the other practices in the state actually doing better. So another question was, how have we seen practices or providers be successful in our PCMH model? And I would say, along with my colleagues, that one of the keys to success for practices in the patient-centered medical home model is focusing on the overall practice transformation. All the staff and providers in the office need to be aware of what team-based care is and how to use it effectively. When the entire team, not just the physician, work from the same playbook by following the same policies and processes, practices run more efficiently and maintain higher performance scores. Developing workflows developing workflows to allow everyone to participate fully is very important. Implementing new processes at an office level can be challenging, but by incorporating representatives from all areas of the staff that may be affected in their development, it can make the change much less abrasive and more widely accepted. Education about the model is what helps people be successful in it. And Blue Cross Blue Shield does provide data to all participating POs and providers to track their performance throughout the year. And we also support our physician organizations in this work by providing funding for all capabilities that the practices implement. And in addition, PCMH designated practices earn 115% of the standard physician fee schedule. And this helps maintain the staffing necessary to support the work and encourages physician organizations, as well as practices and providers, to participate in the PCMH initiative. Next slide, please. All right, so I thought that this was really interesting, and we actually have an adult slide that represents some different metrics, but since we are focused on pediatric work here in this specific group, I only incorporated the pediatric slide. So this data was reviewed internally in 2022, and because we had several years of information, we felt like this was a real validation of our work in the patient-centered medical home space. So you can see, based on this information, that the PCMH practices do perform better, especially in utilization metrics. So I think that this is a real this is very good at exemplifying the work that PCMH practices do and the difference that it makes in patient care, patient outcomes, patient utilization, and overall cost. So I know that that was a lot, and there are some more very specific details, but that's kind of a general broad overview of the PCMH program that we have at Blue Cross Blue Shield of Michigan. I'm happy to answer any questions if anybody has any.
Thank you so much. We really appreciate that and the overview. I know it's challenging to condense into about 10 minutes, so thank you so much for doing that. It is time. We wanted to pause and see if there were any questions for Dr. Huhl. Anything that you'd like to know more about the process, or maybe how that compares with what you've, experienced, if you have experience with that.
Hello, this is Lonnie Barnett with Children's Special Healthcare Services. Thank you for the presentation and the information. I'm wondering, with regard to some of the outcomes or the data that you were sharing in the slides, if data is available distinguishing adult practices from pediatric practices, or is there data available with regard to pediatric PCMHs and the impact?
Though that slide is specific for pediatrics, 0 to 17.
Okay, thank you.
And I was lucky enough to actually work in a practice that had both PCMH and PDCM designations, and I have also worked in practices that don't have care managers. So it was really incredible to see, how much more we could impact patient care when we had some of those additional care team members who you could give a warm handoff to, or you could send a note to, and have those additional touches to make sure that they are getting the resources that they needed.
I have a quick question. This is Carrie Terry. So the performance score that you talked about as being like one of the more challenging aspects of maintaining PCMH status, are on the slide that we're on right now, are these 3 of the data points that that go into that performance score? Is it like a composite score, or can you say a little bit more about that?
So that is a great question, and that could be like a 2-hour presentation from my PGIP field team. So he sent me a slide deck that kind of walked through the methodology, and it's pretty comprehensive. I mean, they really do look at the rate of adolescent and well visits, the rate of vaccination, inpatient utilization, ED, primary care sensitive ED use, and some other quality things that are thrown into. So like the quality bucket gets a little confusing to tease out, but those are the major components that I feel that the practice has control over. So, I mean, sometimes I would argue as a physician that ED rates can be a little bit more challenging, but you know, like the vaccinations, getting people in for well care and making sure they're getting their vaccines, I think that those are the ones that practices tend to focus on. And we set the benchmark at 20% specifically, so it wouldn't be a big barrier to allow patients into the patient-centered medical home model, because we want them to be successful. It's that relative ranking that will sometimes get practices, especially ones that may have a very small pediatric end.
Thank you. That's helpful. Thanks so much.
Thank you. I think we have time for one more question if anyone has something they'd love to ask. And we could also, if something pops up, we can put it in the chat, and I'm sure that Dr. Hunt would be happy to answer it afterwards.
Of course.
Thank you.
Hi, this is Annette Gilmer. I am thinking about the payer mix that many pediatric offices have as far as Blue Cross Blue Shield and then the Medicaid health plans. Is that 115% uplift for payments? In your experience, is that adequate in most pediatric offices that have a higher proportion of Medicaid health plans?
So I can only speak from experience. I worked at IHA, and when we had practices who went from a VBR of 15 and then maybe fell out, it was definitely noticeable. But you make a good point. It is, if there is a high Medicaid population, it may not make a huge impact. It just kind of depends what your demographic looks like in your specific practice. But I will say that in general, practices who perform in this model are pretty payer agnostic when they're providing the services. So even if there's not a huge financial impact to the practice, there's a very big impact on patient outcomes and care.
Thank you. And thank you very much again for, okay, let's say, I feel like hopefully you can answer this one. We'll see if we can answer really fast in the transition.
Oh, I'm sorry. I don't have the exact number of pediatric practices that participate in PCMH. I can reach out and probably get that for you.
All right. Thank you again. We truly appreciate it. And if you do have any other questions for Dr. Hunt, please put them in the chat. And so with that, I'm going to turn it over to my colleague, Sarah McGurr, who's going to help us lead our panel discussion. Sarah?
Great. Thank you so much. Hey, everybody. I'm Sarah McGurr. I use she, her pronouns, and I am with MPHI, and I will be the moderator of our panel today. So we are very lucky to have 3 more system partners with us today that I'm going to introduce quickly, and then we will get to pick their brains. I think, Lindsay, are you able to highlight folks for us? All right.
Yes, I will.
All right. So Lisa DeLernia brings over 2 decades of service as a registered nurse to her role in the Medicaid program. Her journey began in pediatric nursing, where she developed a profound understanding of patient care and access to services. As a practitioner services manager, Lisa navigates the intricacies of Medicaid eligibility, coverage, reimbursement, and compliance, while actively collaborating with beneficiaries, healthcare providers, community reps, and various government agencies. So welcome, Lisa. Thanks for being here.
Thank you.
We also have Kristen Williams, who's joining us as the Clinical Services Manager, Quality Management, for the Upper Peninsula Health Plan. This health plan is managed care and provider service organization that serves residents of the Upper Peninsula, particularly those enrolled in Medicaid, Healthy Michigan Plan, My Child, Children's Special Healthcare Services, and Michigan HealthLink. Her current role involves developing and implementing performance improvement initiatives to enhance service delivery for members. She's also worked closely with providers and administrators to help them navigate Blue Cross Blue Shield's Michigan Physician Group Incentive Program, as well as the patient-centered medical home frameworks. So, welcome, Kristen Williams. And finally, we have Kristen Reese. We're bringing all the Kristens to bear today. Kristen Reese is a family engagement analyst at the Family Center for Children and Youth with Special Healthcare Needs within the Children's Special Healthcare Services at MDHHS. She's the proud parent of a young adult with a neurodevelopmental disability and has spent the last 17 years working to support other families to engage in system-level advocacy. Her passions include being a co-creator of the Care Coordination Empowering Families training. She's trained over 500 parents across 7 different states to develop the knowledge and skills to coordinate medical care for a child with complex medical conditions. Welcome, Kristen. Thanks for joining us. All right, next slide. So just to kind of prime us for this conversation, you might be wondering, how are all these people connected? Well, as Gloria mentioned in our last session, we identified some of these key players in the system. So today we're going to do a deeper dive to learn about the perspective of a few of these system partners. And in this context, when we say system partners, we're meaning individuals or organizations, entities that have that kind of 30,000-foot view. So how a system works at a regional, statewide, or a larger level. So think of, government agencies, policy leaders, insurance providers, funders, et cetera. So this conversation will essentially be data that our group is collecting that each one of us on this advisory committee can use to really understand some of those policies and resources that are impacting healthcare received by children. And there will be time at the end for questions, so you can put them in the chat as you go if you wish, and we'll do our best to address them at the end. And next slide, I also wanted to give you a heads up that you all in the audience have an assignment as well. We will wrap up our conversation today with a question for hoping that each of us in the audience can contribute to. And if someone in my team could please put this in the chat as well so people can keep it in mind. But we're going to be doing a brainstorm at the end based on what we've learned today around this question. What changes do you think are needed to make the medical home approach the standard of care for providers and families in Michigan? So this will just be something to keep in mind and kind of be listening for, because the ideas that we generate through these brainstorms in the next few conversations will serve as a foundation for potential work that this advisory group could decide to tackle. So this isn't just an exercise, this is really the work. So keep your thinking caps on and feel free to pop those ideas in the chat as we go along as well. All right, so let's get started. So for the first question, I'm going to start out with Lisa. Lisa, how do private insurance or Medicaid policies and practices support or get in the way of clinics' ability to adopt or implement a medical home standard of care?
Thank you. So I can really only speak to Medicaid or Medicaid health plan coverage at a high level. But I do also bring a little bit of background information to this conversation in addition to my Medicaid experience. So I'm a registered nurse who worked in a pediatric clinic that was a designated PCMH. I also participated in the Blue Cross Blue Shield PGIP initiatives that were just mentioned. My role in the clinic was that of a case manager and a PCMH lead for kids with very complex medical conditions. And I will say that role for 20 years really has made an impact directly on our coverage determinations in Medicaid. So in Medicaid, we have in Medicaid policy, clinical individuals, nurses, the social workers, and nurse practitioners that help make coverage decisions within our Medicaid program policy area. And as part of that, and also considering the Center for Medicare and Medicaid Services and the American Medical Association have really developed some expansive coding mechanisms to bill for care coordination services. There are many CPT codes and HCPC codes out there that represent case management services. And I'm going to put some links in the chat that will help provide some resources to you. But I will just say, if you just Google billing care coordination services, a ton of information will come up. As a Medicaid program, we cover expansive coverage of in-person care coordination services, as well as many services provided in a virtual, or which means audio-visual component. So cell phones with the audio-visual capability, and also some services by audio only. So for those individuals that don't have the capability, the bandwidth on their phone, we do cover a handful of services by the audio only method. And I will put some links again in the chat to our fee schedules that for audiovisual services, audio only, and our full practitioner services. And on those fee schedules, you can search by code to see what codes we cover, what reimbursement rates are provided for those services. Now, I will say that care management services are, by the code descriptions, are pretty defined in what has to be provided in order to bill that service. Items, there are time requirements, there are staffing requirements, who could bill the service. Usually an RN or a social worker, a licensed RN or licensed social worker is the lead care coordinator. Services are typically, however, billed under the physician's NPI. We, as a Medicaid program, don't enroll RNs, so they can't directly reimburse for those services. But when they're working as part of a care team, that lead team manager, physician, is typically the individual that bills for those services. And I just will add, Medicaid does have to follow within our coverage within federal regulations. There's not really a lot of state regulations that speak directly to care coordination, but 42 CFR speaks to how our Medicaid program can institute and reimburse for care coordination services that are provided through our Medicaid health plans, as well as those provided by our providers in the community. So there it is.
Thanks, Lisa.
Welcome any questions that you have, and I'll put all those
Yeah.
resources in the chat.
Thank you. Yeah, and we'll definitely take some questions at the end. So it seems like, from what I'm hearing, that Medicaid, at least at our state level, has done a lot of work to try to give providers options for billing those care coordination services within what is possible federally. So, Kristen Williams, I know you also have a deep knowledge of healthcare coverage and Medicaid, as well as other state programs. Is there anything else you'd add about how insurance or payer policies support or get in the way of medical home for children?
Lisa did an excellent job. So I work for the Upper Peninsula Health Plan. So we are the Medicaid managed care for the Upper Peninsula. We have about 19,000 members under the age of 17. So I work closely with providers and Medicaid, but my previous role, UPHP, is also the physician organization, so the PO for the Blue Cross Blue Shield PGIP program. So I did that as well. I'm working with practices so we could nominate them for designation, working with the providers, the nurses, the care managers to get those capabilities set. And the one thing I can say in kind of living in both worlds is it's the same. So when I've worked with practices, you're doing the same thing regardless of the payer, right? You're treating all patients the same. Those capabilities are in place regardless. So I think it's important to note that these practices have policies and procedures in place for all of their patients. The other thing I could say is that we want practices to be PCMH designated. It's proven quality of care. It's less cost for a payer because there's reduced hospitalization, there's reduced ER visits. Your you talked about CAP scores earlier. I mean, that's a reflection at a rate for health plans as well. If patients are pleased with their provider and pleased with their access, that reflects on those CAP scores as well. So, we support our providers. I was trying to think of how we get in the way or what barriers there are, but we can talk about that a little bit later as to what the barriers I've seen of implementation, but I guess I would just say overall, it's very supported. The Upper Peninsula, we have 46 PCMH designated practices, and we have 2 pediatric clinics. I will say that the Upper Peninsula, the majority of our practices are just primary care. We do not have a lot of just pediatric specialty practices. So that isn't that alarming that there's only 2. A lot of the practices that are designated have heavy caseload of pediatrics, but they're just considered primary care.
Okay. Thank you so much, Kristen Williams. And I just, as a heads up, it seems like your mic might be a little quiet, so we might need you to adjust something in between. And this is just a reminder to our audience members. I hope you have your thinking caps on regarding the prompt that we talked about. Now, I know Kristen Reese, we've touched a little bit on how, Medicaid or private insurance practices or policies support a medical home standard of care. Is there any thing you'd like to add regarding insurance or maybe other federal or state healthcare policies or standards that might support or get in the way?
At the risk of venturing into politics, and I don't want to turn this into a debate, but I do feel that previous administrations kind of showed a lot of support for these initiatives. I know there were things in the Affordable Care Act that helped kind of do care coordination for people with chronic conditions and Health and Human Services. And I will say that I have some concerns of what direction that will head in. Like I said, I don't want to get political, but with talks of cuts to Medicaid and the Affordable Care Act has been under threat for a long time. What things may be repealed. So I feel that as a parent, a lot of us don't know the inner workings of how those things work. We just know that our kids need care. Our kids need more care than most kids. and finding practices that we work with and can work well with us and support us is difficult already. So the thought of threats to cutting that or changes in policies that may not support those initiatives is concerning. Sorry, I hope I didn't take this in a bad direction, but
No, not at all.
I think that that's on a lot of our minds, because states need federal dollars to implement a lot of these things. They're big changes. I mean, as a family member, the biggest thing for me a lot of the time is time. It takes time to do all these things on the practice end. You know, it takes time to build relationships with providers and providers to build relationships with their patients and families. And if that time is not reimbursed, it's not going to happen.
Absolutely. No, and I think it's very much relevant, the context that we're living in and the discussions around cuts to Medicaid. And, you know, I meant to start us out by saying it's absolutely okay and expected that people on our panels today and throughout our conversations might have different experiences. And that's really critical because we all hold different positions in this system. So I just want to normalize if you need, you know, to respectfully disagree with one another. That's why we have those group agreements, so that we can do that in a way that, you know, still leaves everyone feeling respected and heard. Kristen Williams or Lisa, did you have anything critical you'd like to add about other policies or regulations that maybe get in the way of a medical home for children standard of care?
I don't think so.
No,
They don't want to touch
just
that one.
just that
Sorry.
I can see how that also, I hear that. And, you know, also on the previous presentation from Blue Cross, there for designation, there is that requirement of a quality requirement of metrics. So, I mean, that does come into play with certain quality outcomes in HEDIS. I'm just thinking like immunization rates and areas that, just to tie into what Kristen said, could potentially affect some quality outcomes to practices if maybe more patients are abstaining from some of those recommended, some of that recommended care.
I know you had discussed, were there specific kind of initiatives that you or any kind of folks in this system level space are working on right now when it comes to improvements to policies or regulations that you're kind of hoping to see come to pass?
From the Medicaid perspective, you know, Kristen, you got it. We anticipate a lot of cuts in our funding, and so things really are quiet right now. We're waiting until the federal government passes the budget bill as a final status. Things are quickly changing, ever evolving. And so we really don't know what to anticipate, but other than a reduction in funding, and we aren't sure what that's going to look like. We anticipate it to be significant, but that's really all I can say at this time.
Yeah, absolutely. We're really in the thick of those kind of conversations, aren't we? So it's just a lot of uncertainty. Absolutely. Okay. And it may be the case that once the realities of what those cuts will look like come into focus and the impacts that may have from them, that we may need to hear from you all again about what
Yeah,
kind of...
We
support this
absolutely
community
can
to
do that.
Mhm.
Yes, or I can reach out to our leadership to provide that information. I think that that would be helpful for the
Mhm.
group. Yeah.
Yeah, just so we can kind of be most up to date with what's really happening on the ground there. Mhm. Okay. So now let's talk a little bit about resources. So when we think about resources in systems change, you're thinking about things like information, uh, staffing or staff time, payment, relationships, technology. There's a lot of things that impact the ability for families and practices to make this medical home for children approach come to fruition. So, Kristen Williams, I'm curious if I could hear from you first. What additional resources, from your perspective, are needed to expand the medical home standard of care to more Michigan providers and families?
I'm leaning into my computer. I'll talk loud. Can you hear me better? Okay. Um, I think resources would be staffing is a challenge. Staffing is a challenge for a lot of businesses, but when I think about PCMH and some of the capability requirements of maybe extended hours, on-call services, some of those 15 required core capabilities that were mentioned earlier, sometimes that is a challenge. We've had I know of some practices that have done some like sharing of people and call. They've been kind of creative about that, but that can be a challenge. We have many practices that are kind of one or two man shows without a nurse. Providers are rooming their own patients. Some of this does take time, especially for implementation. As was mentioned earlier, a lot of these capabilities are things that practices are doing already, but it's the documenting, it's the written processes, it's the training, the annual training. That takes time. And sometimes that can be perceived as a burden. So I've worked really closely with practices. We have some that we just consider like provider champions that are really great at sharing procedures and policies to help support other practices in other areas, which has been really exciting to see. I guess I would think that might be one of just the biggest barriers is just that foundational kind of how do I get started?
Yeah, absolutely. I have a follow-up question about the staffing piece. You mentioned it being a challenge because of extended hours or those on-call services. Is it just that it's hard to get staff that are willing to do it on-call kind of role? Or is there something else to it?
So if I can just speak for my landscape here in the Upper Peninsula, we have many bigger systems, not many, that's a stretch. We have a few bigger hospital systems where that isn't such a barrier, but we have, like I said, many practices with maybe 2 providers, some with 1. And, having a call service and being available 24 hours, 7 days a week can be a burden to some of these smaller practices. So like I said, we work and try to be, creative in helping support some of those practices, but that has been a burden. I can tell you that when I work with providers, they want their patients to come to them. They want them to call them. They want them to come to them first. So, they want to be providing the treatment to their patient and not someone else. So sometimes it's just talking through what that looks like and helping support that. But I think that can be a barrier to some of these smaller practices.
Yeah, where you can't be on call 24/7. It's too hard on people. Yeah, that makes a lot of sense. Kristen Reese, I'm curious if you have any perspectives on other resources that you see that could help expand the medical home standard of care to more providers and families.
You mentioned in my bio the care coordination training, which was a project I worked on when I was at Michigan Public Health Institute. And I facilitated probably over 35 trainings with families and at least 500 families that attended that. And the purpose of that training was to help them coordinate care for children with complex medical conditions. And part of that training was talking about a medical home. And I can almost guarantee that at least 90% of people had never even heard the term. Families don't know what that is. They don't know why they want one. They don't know, So we would share, that was part of one of our first activities was going through what a medical home is, what the benefit was. And I am a very strong believer personally that educated consumers are much more savvy consumers of anything. And so I think that, as a parent of a child that has more medical needs than most, not knowing what a practice, there are a lot of barriers on the provider side, some of it being time and staff, and it's hard enough for them sometimes to get at the direct needs, let alone the unvoiced needs of the family. And families often are the ones doing that and not understanding that perhaps there are resources that can share that responsibility, or help them get better care for their child. I think that would help.
So just to make sure I'm following, would you say it's important for families to know that they're part of a medical home because then they know about maybe some of the care coordination resources that they can lean on, that they don't have to do everything on their own. Is that
Right.
correct?
Right. Yes.
Okay. I had a follow-up question also for Kristen. When you mentioned the time piece, that there's, documentation and there's trainings and there's different pieces required, is the time component heavier, like a heavier requirement if
Which Kristen?
oh, sorry, Kristen Williams, 2 minutes, apologies. Kristen Williams, the time requirement for providers, is that heavier if they are trying to achieve and maintain accreditation versus if they just follow all the other practices of a medical home but maybe don't have accreditation?
Both. So for Blue Cross, I'll kind of back up. So UP us as a Medicaid plan, we have some APM, so some different types of payment incentives for providers. Blue Cross or NCQA PCMH designation is a requirement to be able to participate in some of our additional programming. So enable for them to receive additional funding or uplift on care management codes, that's a requirement. So it's both. But in to maintain designation, so I'll speak on behalf of Blue Cross, and I'm sorry, the doctor
That's
certainly knows better than me. But it's a core capability, so it's a requirement. So part of my job was I went into the practices and we would review their capabilities, and they need to annually or biannually provide evidence of their capabilities. So part of what we did was we talked with front staff, we talked with nurses, we talked with providers. How do you notify your patients that you are PCMH? How do you notify your patient if they have a cold or a ear infection to call you and not go to the ER? We would look for documentation and charts of that, happening. We would look for chart notes for a patient that called after hours and that it was documented in the chart. So, in order to maintain that designation, that's something that is reviewed. So it's the uplift of getting there. and being nominated for designation, but it's also maintaining that designation. So it's maintaining that after our, so it would be, hey, if you have a patient that calls with an earache, show me in your schedule where that time would be allowed for that member to be seen. So, designation is really, it's a special thing, right? It's important, and it's, you're doing things maybe above and beyond what other providers are. So it's twofold. It's getting there and then maintaining that as well.
Mhm. Okay. Thank you so much. I know I'm just looking at our time. Um, did anyone have anything else they wanted to offer regarding resources that are needed to help expand the medical home standard of care? Okay, great. Well, then I'm going to move us to our last question to wrap up our time with our brain trust today. And I know that next time we'll have the opportunity to hear from providers and parents as well. So we look forward to those perspectives and how they might be the same or different from the folks we have today. But I'm curious to hear from you all. What opportunities do you see for key partners to move the medical home standard of care forward in Michigan? What do you see as key opportunities to keep growing this model? And whoever wants to go first can chime in.
I'll repeat parents. Parents, I think, are key partners and could be key partners in moving it forward. If they don't even know what it is, they don't know to ask for it. They don't know to, reach out to the provider and know that's something they can do versus going to the emergency room. They don't know there might be additional supports there that they could utilize.
Yeah, great point. Yeah. Thank you for uplifting that kind of perspective. I'm curious, Kristen or Lisa, if is notification of that this is a patient-centered medical home and patient education on that a part of any sort of quality standards or accreditation standards? This is Kristen Williams, or at least probably Kristen Williams would know
Yeah,
most about it.
Kristen, yeah, it wouldn't be relevant to Medicaid fee-for-service.
No. I'm
Okay.
sorry, repeat the question.
Oh yeah, no, I was curious if there were any kind of accreditation standards or quality standards or anything that kind of require around how a provider educates parents or families about medical home model and the availability of those services.
No, but it's something that I just want to say I'm super impressed with Kristen Reese. Like, amazing job with all that what you've done with your advocacy. A great job. But I would just say it's that continued education of just, this is where you need to go. This is your provider. This is who you need to call. And that's quality of care. And like I said, most providers want that, and they're doing that. But I think, going back to what Kristen said, we also, a population of, you went to your doctor when you were sick, and that was it, right? You didn't go to the doctor annually just to make, to say, I'm doing great. And, you didn't do that. So ER and urgent care is where you went when you had an earache or when you had a sore throat. So I think it's just a lot of, just like we've talked about, and I know we've said it a lot, but just educating patients on, this is where you need to go. It's important that you're seeing your same provider. They understand you. They know your medical history. They want to see you. You can call them, and they will be able to see you within a day or two. And if they can't, they'll direct you to somewhere else. But it's just kind of a redesign of what those medical appointments look like. It's important for preventative care. Your doctor wants to see you even when you feel well.
Mhm. Okay. And Kristen Reese, I'm curious if there's any other, in addition to, for example, the fabulous training that you have helped to develop and deliver, is there any other kind of systems based opportunities you think that could support parent education about?
Well, I'm now at the Family Center at Children's Special Health Care, and a large portion of what we do is education to parents. Um, we hold, monthly webinars. We talk with parents. We support and empower them to build relationships with their providers. We do education on medical home, and we work with all families. Um, so there are organizations, that work with families from a peer-to-peer model. And I think that is probably one of the more effective ways. It's one thing to hear your doctor tell you something, it's another to hear another parent say, hey, this is what worked for me, right? So I think those models are important to support and sustain, when looking at, patient education and things like that.
Great. Thank you so much.
Little plug for my own.
Hey, yeah, you're doing great things. Lisa or Kristen, are there any other opportunities that you see for key partners to move the medical home standard of care forward in Michigan?
I think that someone mentioned earlier staffing.
Oh, I think Lisa might have frozen up.
I would
Lisa,
just say continued conversation, continued collaboration, just continue talking about this. It's very important.
okay. When you say collaboration, who comes to mind for you?
This meeting,
Um,
just getting. I love that there's just the picture that you had of all the players of just everyone who has a touch in this patient and what their journey looks like. Just continued collaboration and discussion and support.
Thank you, Lisa. I see you were having some connection issues, but you said growing the workforce. It looks like you're back now. Do you want to expand on that?
I just think that Kristen Williams had referenced that it's very difficult for practices to fully staff their offices with a receptionist, with a nurse, with a physician for after hours care. It's not even that individuals aren't willing to work that, it's just there's physically not enough bodies to fill those positions.
Specifically for all those types of roles for nurses and office workers. Okay, physicians. So there's some workforce development that needs to happen in a lot of different kind of healthcare spaces, if that's fair to say. Okay. Anything else you want to share before we open it up for audience Q&A? All right. Well, thank you so much, Lisa and the Kristens. We're going to take a few minutes to get questions from the chat, but I'm going to open up to any verbal questions people might want to ask first. Feel free to unmute. Ask your question. Got a lot of people a little quiet today. A lot of good thoughts coming around.
Well, I'll just jump in. I have to ask this question about workforce. It seems to me a real pivotal thing, even if parents are educated on what a PCMH is and they would obviously want to be a part of that. If there isn't resource, if there aren't facilities that are offering that, I don't know what choices they have. So are there any models in the state or in the country where some of these resources maybe are shared or creative ways of providing? I asked a question about care coordination. I don't see how you can have a PCMH without a care coordinator and in a busy practice with really limited staff. There's nobody to do that, right? Is the real problem. So I guess, are you aware of ways that can be creatively resolved with cost sharing or some other approach?
Great question. I'll just open it up to any of our panelists that may have heard what other states or regions are doing. Looks like nothing's coming to mind immediately, but seems like fruitful ground certainly for conversations to continue either at the state or national level. I mean, Kristen, you spoke about just kind of provider to provider, there being some resource sharing around some of those procedures, for example, to kind of lessen the load of trying to tackle everything you need to do to get on board with the model. But yeah, that's a good question for us to explore further. And if anyone in the audience knows of any models or approaches happening elsewhere that they could share about, please do.
Can I just extend on that a little bit? Because I'm guessing like somewhere someone has done some modeling about how many patients would need to see a care coordinator to be able to bill and sustain that position. And I'm sure there's a lot that goes into it, and there's probably no one magic number, but I'm guessing for larger practices at least, like those kind of calculations have been done, and wondering if it's really the small practices that kind of fall through the cracks with that, if anyone has thoughts on that.
I have seen that, and I don't recall off the top of my head what that is, but there is that. I believe that was through the PDCM training that I took through Blue Cross, really mapped out like a day schedule of what that looked like. The barrier that I see with that is, especially with small practices, having that designated care coordinator can be hard when there's a sick call or there's a crisis in the office. Nurses tend to be very helpful and they want to really work with their team. And, if there's somebody called in sick and there's 5 patients needing assistance in a waiting room or it's hard for them just to sit in an office and, make some calls. I was out at a practice yesterday meeting with the care manager, and she told me that the previous week she had to fill in for the receptionist. And as I was with her, she was mentioning that she also draws blood. So she might have to step out of the room because she's drawing the blood too in a small practice. So that's where we see that. Also, care management can be hard, and there's burnout, and it's kind of this revolving door of I've seen that with practices. They get up and going and they're doing great, and then their care manager leaves, and then you have to start over with your training, and it's almost essentially like 8 months before they're really confident with dropping their codes and having their system. So that can be a big barrier.
So not only kind of recruiting people, but retaining people, and particularly in the care management, care coordinator kind of role. I'd be curious to know also if there's anybody in kind of rural health tackling any of this, if there may be a preponderance of small practices in rural areas potentially. Any other questions from the chat or Lindsay?
Yeah, there are a few. One person asked, Dr. Gilmer asked, is a full-time care coordinator or position needed in a practice to be a PCMH designated? Or are there other ways for the service to deliver? for the service to be delivered. And then that's one. And then right below it, there was a question about like RN and certified social workers, the only individuals allowed to bill for care coordination services. It's just a couple of real quick questions there.
So yeah,
So,
go ahead.
oh, sorry, Sarah. So care coordination services can be billed by a practice regardless if they're a PCMH designated practice or not. The PCMH designation absolutely bolsters a practice and provides a revenue stream to support the additional staffing that is often required for care coordination services. But Medicaid does cover care coordination services regardless of PCMH status. The coding guidance in the AMA code books, physician practices, billers are very aware of coding guidance and limitations within codes. It is pretty straightforward, very, very descriptive of what must occur for care coordination services to be billed. And it is not extremely complex. It's pretty straightforward. I think one of the problems is a lot of practices don't know what they can bill for, that these codes are available, they're reimbursable. And we've had communications with practices, with providers in the community to inform them. And they're always surprised. So.
Okay. Yeah, so there's some like a resource in that case could be, yeah, information about what those codes are and how to bill for them. And yeah, there's also some maybe staffing considerations around you have to have an experienced biller who knows about the opportunity to take advantage of that. Did we answer the first question? The first question was, in your opinion, does there need to be a care coordinator on site to have an effective PCMH, right? And I think Lisa covered in terms of Medicaid standards. Kristen, Williams, do you happen to know if a care coordinator is a requirement of accreditation model or from Blue Cross Blue Shield or otherwise?
I'm probably pronouncing it wrong. Dr. Han, is that how you say the name? So I heard
It's Dr. Huhn.
Huhn. Okay, I heard you earlier say that you're more involved with PDCM. So correct me if I'm wrong. In order to be PCMH designated, you do not. But in order to participate in PDCM, you do need to be designated, correct?
You have to be designated as a PCMH practice to get to be involved in the PDCM program. Yes.
Do you have to have? Yeah.
But you can be PCMH designated and not participate in PDCM.
100%. Yes.
So the answer to that question is no. You don't need to have a coordinator to be PCMH, but it's certainly helpful and it yeah.
It's certainly helpful. And even in the PDCM program, you don't have to you just have to have someone who's dedicated, has time dedicated in their schedule to provide the patient services. So it doesn't necessarily have to be a care manager.
Okay.
But that does dictate what codes you can bill. That's where it gets a little trickier.
Okay, sure. Thank you so much. I love just all this resource and knowledge sharing, such incredible folks in this group. Well, as I kind of bring our panel to an end here, I just want to thank our presenters and for sharing, all of their wisdom and knowledge with us and helping us distill really complicated topics into things that we can all understand. So really appreciate that. And we look forward to hearing from the kind of direct provider and parent experiences some more in the weeks to come. And yes, Lindsay mentioned any kind of unanswered questions after the session. We will see if one of our presenters might be able or willing to address those at some point in the future. So thank you so much. I'm going to invite us all to start our brainstorm. So start thinking about what changes did you hear today that are needed to make the medical home approach the standard of care for providers and families in Michigan. So this is that kind of like what ideas came to mind for you all in the audience as you heard our systems folks talk about this. And just as you're kind of brainstorming that, you can throw those in the chat. I'm going to invite Sarah Davis, who wants to just share an opportunity with us.
Thank you, Sarah. Yes, it's an unrelated opportunity, and Jessica will follow up with more information, and I can drop it into the chat as well. But we just wanted to take the opportunity, given the group of you that are here today, to share a training opportunity that we have been working with the AAP on. It is an HPV communication skills training, and it is available for anyone who works in an office setting, pediatricians, office staff, nurses, nurse practitioners, PAs, community health workers, doulas, etc. It's a 4-module training. It is free. There are associated CEs or CMEs through the AAP that are available. So thank you for the opportunity to give a little plug about that. I will drop information in the chat, and feel free to reach out to me if you would like any additional promotional materials to share with your networks. The training is available through the end of July, so we're just hoping to continue pushing out word about the training opportunity this summer. So thank you, Sarah.
Thanks, Sarah. That sounds really exciting. I hope folks take advantage of that. So I see we have an idea in the chat so far. What changes do you think are needed to make the medical home approach the standard of care for providers and families in Michigan? I see Vanessa mentioned changing the mindset of folks. And Lindsay invited them to share more. What other changes did you hear today? Annette says, making provider offices more aware of billing opportunities for care coordination. Absolutely. That stuck out to me too. Carrie Terry says, more discussion on the care coordinator or care manager position. Maybe some opportunity for changes there. Julia says, I wonder if there's ways for pediatric care providers to partner with local health departments on workforce development strategies related to care coordination. Yeah, especially in those small clinic, settings. There's ways to do some of that cost sharing somebody mentioned.
I will add that I think just a more coordinated approach to healthcare is needed in terms of the philosophy of care. As Kristen mentioned, we're not used to, a lot of people aren't used to going to their doctor for well visits or, and care has gotten so specialized. I mean, you used to go to your family doctor and they treated you for everything, right? Now you go in and, oh, I've had these belly aches. Well, off to the GI you go. The doctor doesn't even begin to treat it. They send you to specialty care. And I think there's benefits and downfalls to that, because if the providers aren't talking and the parents in the middle trying to coordinate, it gets really frustrating. And having been in that position where, the specialist is telling you one thing and then you go back to another doctor and they tell you something totally opposite, and, you have different healthcare systems. So, nobody really is looking at the big picture, and it can, other than sometimes the parent, but even they get overwhelmed, so
Yeah,
I think that just, that philosophy of care being more coordinated. I think it's done well in pediatric care, but the minute you hit adult care, the shift changes, and it's kind of, you're on your own now.
Absolutely. Thank you. Thanks, Kristen. All right. Well, we are nearly at the end of our time. So if you are able and willing, please keep populating in the chat your ideas. Thank you so much for all of your contributions today. We're putting you to work, and this is certainly, I'm learning a lot through these conversations, so I hope you all are too. Our next meeting will be just 1 hour long, so a little bit shorter than usual, and that will be coming up on June 4th. So pretty soon here. This will feature parents and healthcare providers. We'll be talking about, experiences with some of those policies and kind of the structural pieces. And with that, we do have an ask out. We are still looking for two parent representatives to serve as panelists for that conversation. So their role will be just to talk about their experiences and how, things like insurance or other kind of rules and or resources that they do or do not have access to, how that's impacted healthcare for their children. So if you are interested in being a parent, now that you've seen what a panel looks like and it's not very scary, please reach out to Lindsay or Jessica Hamill. And last but not least, please do complete our evaluation. The link is in the chat. We look at the results every single time, and every comment that you make is important to us, and we integrate them into our facilitations to make sure that these meetings are as useful as possible. This is a topic that we all care deeply, deeply about. We want to make sure this time together is as efficient and effective in building the collaborations needed to improve our systems together. So please, whatever feedback you have, we want to hear it. Thank you so much. And on the screen is the contact information for Jessica Hamill and Lindsay DeBoer. And we hope to have a couple parent reps be willing to sit on our panel next time. So thank you so much, everyone. Appreciate you. Oh, and thanks, Tia. Have a great rest of your week.